You know that involuntary flinch, that sharp, sudden intake of breath you do right before a nurse even comes near you with a
Oh
needle?
yeah, the anticipatory wince. It's basically the brain's threat detection system firing up, essentially preparing the physical body for structural trauma before the skin is even breached.
Right. And we accept that trade-off in medicine all the time. I mean, you endure the pain of setting a broken bone or getting a vaccination because you understand the long-term benefit.
Exactly.
But take that anticipatory wince and multiply it exponentially when you start talking about introducing high-powered lasers and radiofrequency microneedles to, frankly, the most sensitive, intimately innervated areas of the human body.
Yeah, the vulnerability of the pelvic region makes any medical intervention down there highly anxiety-inducing. The psychological barrier to entry is just massive when you combine the words thermal energy with vaginal tissue.
Which is exactly why we are cutting straight through the glossy medical marketing brochures today. Welcome to today's deep dive, where we are exploring the rapidly expanding world of intimate exosome therapy.
It's a huge topic right now.
It really is, and we've pulled together a massive stack of sources for you. We've got clinical overviews from the Cleveland Clinic, regulatory safety data from NICE, the National Institute for Health and Care Excellence, along with warnings from Safe Face UK.
And we also cross-referenced all of that with what high-end aesthetics clinics in London and massive medical tourism hubs in Turkey are actually doing on the ground.
Right. And our mission for you today is singular. The idea of undergoing a regenerative procedure in such a sensitive area naturally makes you wince, so we are answering the most heavily searched, burning question about this procedure. Does it actually hurt?
And to accurately answer the pain question, we really have to look at the payload first. We have to understand the biological mechanism of what is actually being introduced to the tissue, because the nature of exosomes themselves fundamentally alters how the body responds to the physical procedure.
Yeah, because most people hear regenerative medicine and they immediately picture live stem cell therapies, right? Which, carry their own massive set of risks, like immune rejection or unregulated cell growth.
Right, which is a huge concern.
Hmm.
But the clinical data emphasizes a really crucial distinction here. Exosomes are not live stem cells.
So what are they exactly?
They are essentially the microscopic debris, or like byproducts cast off by cells, usually mesenchymal stem cells, which act as the body's natural repair contractors. So exosomes are entirely cell-free. You can picture them as a highly resilient, nanoscale biological envelope.
A biological envelope. Okay.
Yeah. And because they are not living entities, they don't possess a nucleus, they can't spontaneously divide. So your immune system doesn't immediately flag them as foreign invaders to be destroyed.
But if they aren't alive, how are they executing these massive regenerative changes? I mean, the literature shows them dramatically reducing local inflammation, stimulating fibroblasts, and triggering angiogenesis, which is the creation of brand new blood vessel networks.
Right.
How does a dead envelope pull that off?
Well, it all comes down to what is inside the envelope. They are packed with a really highly concentrated payload of bioactive molecules. We're talking specific proteins, lipids, and messenger RNA.
Okay, mRNA.
Exactly. So when an exosome comes into contact with a damaged or aging cell in your body, its lipid bilayer actually fuses with your cell's membrane. It dumps that messenger RNA directly into your cell.
I love this concept. It's essentially like little cellular text messages being sent to your aging or damaged tissue, and the text just says, hey, wake up, it's time to repair and rebuild.
If we connect this to the bigger picture, it's pretty profound. That RNA gets translated by your own cellular machinery. You are providing the exact biological blueprints required for the tissue to behave as if it were decades younger.
Oh, wow.
Yeah, it represents a foundational shift in medicine, really. We're moving away from just treating symptoms, like using synthetic estrogen creams or temporary lubricants. This therapy attempts to actively regenerate the structural integrity of the mucosa itself at a cellular level.
But wait, if these nanoscale envelopes are so incredibly potent and they have the ability to just naturally fuse with target cells, I have to challenge the methodology here.
Go for it.
Why are we dragging energy devices into the equation? Why can't a patient simply apply an exosome serum topically and just let those envelopes do their job? Why introduce lasers to such a sensitive area if you literally don't have to?
Well, because the human mucosal barrier is brilliantly designed to keep things out. The superficial layers of the vaginal epithelium are extremely tough. I mean, they are built to withstand friction and protect against pathogens.
So a cream just sits on top.
Exactly. If you simply apply an exosome serum topically, the vast majority of those nanoparticles will just sit on the surface and eventually be flushed away. They will never reach the lamina propria, which is the deeper layer of connective tissue where your fibroblasts actually live.
Okay, let's unpack this. You're telling me they're using lasers and microneedles in the most sensitive part of the human body to forcefully bypass that barrier? That sounds inherently absolutely painful.
It sounds violent, yes. The practitioner have to create microchannels to act as an express delivery route for the exosomes. And they do this using some fairly intense energy-based devices.
Like the ones in our sources, right? The fractional CO2 lasers like the CO2RE Intima or the Mona Lisa Touch.
Right. Or devices like Morpheus 8V, which utilizes radio frequency energy delivered through actual microneedles.
Okay, driving heated needles into the tissue.
Yes. The physics of these devices serve a dual purpose. First, they physically puncture or ablate that superficial barrier. But second, the thermal energy they deposit triggers an acute wound healing cascade.
So you are purposefully causing localized trauma.
Exactly. When you apply the exosome serum immediately after, those nanoparticles flood down into the microchannels. They hijack that natural wound healing response, using the acute inflammation as a catalyst to hyperaccelerate tissue regeneration.
I understand the mechanism, but this brings us to the ultimate paradox of the clinical data. You were talking about fractional ablation, literally vaporizing microscopic columns of tissue or driving heated needles into the vaginal canal and vulva.
Yeah.
Yet the patient reviews and the clinical literature overwhelmingly describe this procedure as virtually painless or cite only mild discomfort.
It's hard to believe, right?
I am really struggling to reconcile the violent physics of a fractional laser with the sensation of a light, warm vibration. How is that neurologically possible?
It's actually a combination of aggressive upfront pain management and the unique neuroanatomy of the female pelvic region. Let's look at the external tissue first. The vulva and the introitus, which is the vaginal opening, have a remarkably high density of somatic nerve endings,
So they're highly sensitive.
extremely sensitive to sharp pain and temperature.
So that area would absolutely register a laser as a severe burning sensation.
100%, which is why clinics utilize highly compounded topical anesthetics. They apply very potent lidocaine and prelocaine gels, allowing them to thoroughly absorb into the external mucosa for 20 to 30 minutes before the device is ever even powered on.
Okay, so the somatic pain receptors are basically chemically blocked from transmitting those distress signals to the brain.
Exactly. But internally, it's a different story. You can't heavily coat the entire internal vaginal canal with a potent topical anesthetic.
Right, because the mucosal tissue is too absorbent, so you'd run a massive risk of systemic lidocaine toxicity. So how are they managing the internal pain?
Internally, the neuroanatomy changes dramatically. The upper two-thirds of the vaginal canal are primarily innervated by the autonomic nervous system, not the somatic nervous system.
Meaning it literally doesn't process pain the same way your skin does.
Exactly the opposite of the external tissue. The internal canal is highly sensitive to stretch, to pressure, and distension, but has very few nociceptors dedicated to sharp cutting or burning pain.
Wow.
So when a slim, sterile laser probe is inserted and rotated, emitting those fractional pulses, the brain simply doesn't have the hardware in that specific area to interpret it as a sharp injury. It just translates the energy as a generalized warmth or a dull vibration.
See, that makes the clinical descriptions of the sensation much more logical. But it also relies heavily on the engineering of the devices themselves, right? We aren't talking about a continuous laser beam just cutting through tissue like a scalpel.
Oh, not at all. The calibration is microscopic.
Yeah.
These devices operate using pulses that last fractions of a millisecond.
So it's super fast.
Very fast. They respect what's called the tissue's thermal relaxation time, meaning the heat is delivered and dissipates so rapidly that it doesn't have the opportunity to spread and cause deep, uncontrolled nerve trauma. The injury is strictly confined to the superficial mucosa.
So the procedure itself, which our sources say generally takes about 15 to 30 minutes, is highly managed. The patient is completely awake, there's no cutting, no stitches, no general anesthesia, and the physical sensation is heavily mitigated.
Right.
But what happens when that external numbing cream wears off?
Well, the inflammatory phase of the wound healing cascade kicks in. For about 1 to 3 days, you will experience localized vasodilation.
Which means blood rushing to the area.
Exactly. Which presents as redness, mild swelling, and a feeling of hypersensitivity or warmth. But the downtime is actually minimal regarding your daily activities. Most patients can return to normal activities the very next day.
Though the primary logistical restriction across the clinic protocols is that you must abstain from sexual intercourse, right?
Uh,
And often avoid using tampons for anywhere from 5 days to 2 weeks.
yes. The tissue is in a highly active state of remodeling, and those microchannels need time to fully close without the introduction of mechanical friction or external bacteria.
So it requires a brief period of physiological rest.
It does. But, this brings up a deeply fascinating psychological component. You are asking a patient to volunteer for a procedure that involves financial cost, clinical vulnerability, and several days of localized swelling and sensitivity.
Right. So what does this all mean? We have to look at what drives a patient to make that trade. And the reality is that this highly managed acute procedural discomfort is being utilized to cure a much more severe, chronic, and deeply debilitating state of pain.
The medical term for it is dyspareunia, which means painful intercourse. To understand why someone would undergo laser therapy and exosome treatments, you really have to understand the structural degradation that causes dyspareunia in the first place.
For many women, it's driven by severe hormonal shifts. Like during perimenopause and menopause, as systemic estrogen levels plummet, the vaginal tissue literally starves. The mucosa thins out dramatically, it loses its natural elasticity and its ability to produce transudate, which is the body's natural lubrication.
It's vaginal atrophy.
Hmm.
And we also see it frequently in postpartum patients. Severe tearing or episiotomies during childbirth can heal with dense, rigid, fibrotic scar tissue.
Right.
And that scar tissue completely lacks the flexibility of healthy mucosa.
So whether it's from atrophy or fibrosis, the end result is the same. The mechanical friction of intimacy causes severe micro-tearing of the tissue.
It's awful. Women describe it as a sensation of burning, tearing, or feeling like sandpaper. It completely shatters a person's quality of life, their intimate relationships, and their confidence.
And this is where the regenerative combination of the microinjury and the exosome payload acts as the cure. By forcing the fibroblasts to synthesize new collagen and elastin, the mucosal walls physically thicken.
Exactly. The radiofrequency microneedling physically breaks down those rigid postpartum scars, while the exosomes instruct the body to replace them with flexible, healthy tissue.
And the angiogenesis, those new blood vessels, restores the natural fluid mechanics of the tissue, completely eliminating the dryness that causes the friction in the first place.
It's remarkable. You're trading 20 or 30 minutes of clinical vibration and a weekend of localized swelling for the potential of months or years of pain-free, normalized intimacy.
When framed against the chronic daily reality of dyspareunia, the mild discomfort of the procedure makes total sense.
Highly acceptable. And the biological remodeling takes time, usually peaking at around 3 months post-treatment, with maintenance protocols suggesting a follow-up maybe every 12 to 18 months.
But we do have to look at the broader safety picture here, because the margin for error is razor thin. If this entire process relies on perfectly calibrated thermal relaxation times and the precise biological signaling of exosomes, what happens when something goes wrong?
This raises an important question because the regulatory landscape surrounding this is incredibly fragmented right now. It's basically a regulatory Wild West, largely because the technology is outpacing the legislation.
Let's examine the exosomes themselves. The clinical consensus is that mesenchymal stem cell exosomes derived from human sources like adipose tissue or umbilical cords offer the most potent regenerative signaling for human tissue.
But SafeFace UK, which tracked aesthetic complications, issued a massive safety warning. They point out a huge legal hurdle. Human-derived exosomes are currently not legal for aesthetic use in the UK.
Right. Clinics there are limited to using plant-derived or sometimes animal-derived exosomes, which might not have the identical mRNA signaling capabilities.
Yet, if you look at the medical tourism data from Bukimed, Turkey has built a massive, booming industry around this exact procedure.
Oh yeah, it's a massive industry.
Clinics in Istanbul are performing thousands of these sessions annually, freely utilizing human-derived exosomes, with the average procedure costing around $1,800.
So this global inconsistency essentially forces you, the patient, to become your own regulatory advocate. You have to vet your practitioner heavily. You have to demand absolute transparency.
Absolutely. You need to ask, are you getting sterile, single-use vials? Can the medical professional clearly articulate the purification and isolation process of the exosomes they are using?
Right. If they brush over the origins of the biological material, that is a massive red flag. Hard stop.
But the biological material is really only one half of the risk profile. The true danger of severe pain doesn't usually come from the exosomes. It comes from the delivery device.
Yeah, placing a high-powered fractional CO2 laser or a microneedling device into the hands of an untrained practitioner is where catastrophic complications occur.
The clinical overview from NICE highlighted a specific case study that perfectly illustrates this. A 55-year-old woman sought out laser therapy just to manage mild menopausal dryness.
Okay.
But after 3 sessions, her condition didn't improve. It actually deteriorated rapidly.
Yeah.
She developed severe insertional pain, chronic pelvic floor spasms, and intense scarring along the vaginal walls.
Oh my God.
She required extensive physical therapy, vaginal dilators, and specialized medications just to mitigate the damage caused by the device.
That is horrifying. But that case study is a textbook example of bulk heating and operator error, right?
Exactly. If a practitioner uses energy settings that are too aggressive for the specific tissue type, or if they lack the manual dexterity and just linger too long in one specific spot, they surpass that thermal relaxation time we talked about.
So the heat doesn't stay confined to a superficial microchannel. It penetrates deep into the muscularis layer.
Yep. The tissue sustains a full thickness burn. And how does the body heal a severe burn?
With massive amounts of rigid fibrotic scar tissue.
The irony is tragic. A poorly calibrated device literally induces the exact structural fibrosis and mechanical pain it is marketed to cure.
And the clinical warnings from the Cleveland Clinic echo this too. They cite risks of prolonged numbness, urinary incontinence, and ironically, worsened dyspareunia if the thermal energy damages deeper nerve plexuses.
Which is why you aren't just shopping around for the most concentrated exosome serum. You are trusting an individual to safely wield a thermal weapon inside your body.
You need a board-certified professional who understands pelvic floor dynamics, the physics of laser tissue interaction, and neuroanatomy.
It requires a practitioner who views the procedure through a holistic gynecological lens, rather than someone just, applying a predetermined setting on a machine. The technology is phenomenal, but it is entirely operator dependent.
So, to bring it all together for you today, does intimate exosome therapy hurt? Well, the actual procedure itself is highly managed. Thanks to numbing agents and the natural lack of somatic pain receptors deep within the vaginal canal, you are really just looking at 30 minutes of warmth and vibration, followed by a few days of mild localized sensitivity.
Right, it's a 30-minute mild discomfort designed specifically to treat chronic, life-altering pain.
But the safety of that delivery method is absolutely paramount. You are trading the anticipatory wince for an epigenetic software update, but only if it's done correctly.
Exactly.
But I want to leave you with a final thought to mull over or explore on your own. As regenerative medicine advances, we are clearly shifting away from the era of symptom management. We are moving past taking pills and applying synthetic creams and learning how to deliver precise, microscopic blueprints that simply instruct our cells to physically heal themselves.
It's the future of medicine.
It really is. So if we can successfully harness these cellular text messages to reverse structural atrophy and eliminate chronic pain in our most intimate, vulnerable tissues today, what other chronic human pains, what other failing organs or deteriorating joints might we simply instruct our bodies to fix tomorrow?